Okay, so thanks everyone. Thanks, Joe, for the invite. It's lovely to see some friends, familiar faces, and I always love being here. So, my colleague Heather Shaw is going to talk after me to talk about clinical trials that we're very involved with. A few of you have been asking me about trials that are either ongoing or coming along. So I'm not going to address any of that in this talk, but Heather's going to follow on with that, and you'll have a good view about what we're doing at the moment and what's available and what will be available shortly. I thought what I would do is talk to you about how to find somebody who knows something about this rare disease. Because I'm sure within the patient forums and also in my own practice, it's really common that you meet people who have got very little experience. And in fact, we've just been through the NICE assessment for tebentafusp, or the appeal with tebentafusp. And I hope that we're going to get it over the line this time. We'll see. But there was an issue that NICE were asking for expert opinion. And I would say not all experts were experts in uveal melanoma. And so with an ultra-rare disease, I think it's really difficult for patients and their families to figure out who is giving them sensible advice and who's not giving them sensible advice, because the reality is that it's quite complicated out there. So I thought I'd talk about that to you today, how to find somebody that knows something about this disease. And then the other thing that I thought I'd mention was about next generation sequencing. And we've heard something just now about the potential for precision medicine, personalized medicine. Potential is not the same as current delivery. And I'll show you why next generation sequencing is inappropriate for the vast majority of people with uveal melanoma. There's really good reasons for it, and you'll just spend £3,000 for nothing. I feel quite strongly about it because I think people are taken advantage of. So I'll explain that to you as well. Okay. So let's go. Next slide. So, we all identify experts in all walks of life. Whether it's your mechanic or your plumber or your electrician or whatever. So how do you do it? Well, you ask a friend. Now, most of you will not have friends, even through OcuMel, but most of you will not have friends who've got in-depth experience of uveal melanoma. Certainly before you come to OcuMel, it's one of the things that OcuMel offers. You'll read reviews, but then the question is about who's writing the reviews and what's their perspective. You'll look at their qualifications, but all of the oncologists that you'll come in contact with have got lots of letters after their name, so they're all qualified to do something or other. You'll ask another professional and you'll follow your gut feeling, but the consequences of getting it wrong, if you've got advanced eye melanoma, are very different from the consequences of getting your electrician wrong or your plumber wrong. Next slide, Joe. So I think medical expert opinion is particularly challenging, and it's even more challenging with rare cancers, because the truth is that even, most melanoma doctors do not see a lot of uveal melanoma. And everybody looks well qualified, because they are well qualified. They're all really bright, and they've got their medical degree, and they've been to good medical schools and all the rest of it. But how do you as a patient assess the depth of their knowledge about your specific disease, uveal melanoma? And even more difficultly than that, how do you assess the quality of their decision-making? And I think it's increasingly not helped by direct marketing from doctors' websites that you see in the private sector, because they'll all say wonderful things about themselves. So next slide. So let's just run through how you would do it. So the first thing is about reviews and testimonies. So the question is, who's writing it and what do they know about the subject? What do they actually know about? So if you've got somebody with very little experience writing a glowing review, how good is the glowing review? So I'm a bit of a foodie, so I'll never look at a TripAdvisor restaurant guide, a restaurant review, because they're all written by overexcited US teenagers on tour in Europe, getting really worked up about the wonderful pizza that they've had, and they'll write a 5-star review. Okay, so the quality of the review is based upon the experience of the person writing the review. And if you're an eye melanoma patient going along to a doctor and you've never had eye melanoma before, because of course nobody's had anything like this before, and you hear something that sounds good, you'll write a good review. But what does that really say about the doctor that you're writing the review of? Okay. So patient experience may not reflect the key indicators of quality. It could, of course, reflect the quality of the communication at the consultation, because we all know that. You all know when, if you sit in front of somebody, whether they'll be nice and polite and appear that they know what they're talking about and treat you with the respect that you'd be due. So you'll pick that up, because we all do that all the time, but it won't reflect the knowledge or the quality of the decision making. And it's difficult because you may feel that you've had a useful, insightful consultation, but actually you may not realize that the quality of the decision making is poor. It may feel good to you, but you haven't got that sense check to know that what's been said to you is actually sensible and has a reasonable perspective. So you have to do some due diligence, I'd suggest, on the people that you're going to. Next slide. So there are some indicators of quality, I think, that are useful. So the first is, where are they? Where's this doctor working? Are they working in the NHS? Are they working privately? Are they working only privately? I think that's a red flag, personally. Okay, so it's a red flag for a number of reasons. There's less oversight, and there's if you're a top-end doctor, you want to do some research, you can't do that in the private sector. You can only make money in the private sector. You can't do anything academically interesting. So if somebody's only in the private sector, I ask a question, well, why? What's happened to their NHS practice? Because, well, you can't run any trials in the private sector. And then university affiliation. Well, there are hierarchies of universities. Everybody knows, if you've got kids going to university, they'll apply for Russell Group universities or not. So there are hierarchies. So whether you're at Oxford, Cambridge, UCL, I have to say UCL because that's where I am. It's a bit different from if you're in the Anglia Ruskin University. I chose that specifically. So some institutions are higher quality than others. So you can, it's all on the internet. You can have a look. And coming back to the private, so I've got a private practice, and some people here are my private patients. So it's not that I have a negative opinion about private practice. I have a negative opinion about only working in the private sector, because that's not where most of the important things happen. So there can be a false impression of excellence in the private sector. Everything looks nice and shiny, and there's carpet on the floor, and you'll have a concierge at the front door. And there is that sort of Harley Street myth that if you're on Harley Street, that you must be really good, you must be really top end. So my dad, unfortunately, died from colon cancer probably about 10 years before he should have done. And he went to see a gastroenterologist in Harley Street, and he used to make a joke. He was saying, he used to say he saw the top bottom man in Harley Street. I always remember that. Well, the top bottom man in Harley Street let him down because they didn't pick up his change in bowel habit. So just because you're in Harley Street, and I'm speaking as a Harley Street doctor, just because you're in Harley Street, it doesn't mean that you're giving good quality care or you're top of the game. You're not. It's not what defines you. What defines you are the people you work with, the institution that you work at, other things that you do. Next slide. So what are the indicators of quality? Well, again, if you just Google an individual, you can see this. Are they involved with expert guidelines? So to write guidelines, you have to be invited onto the guideline. In fact, that's not quite true, because we started the guidelines process in 2014 for eye melanoma, and I invited myself on it because I thought it was a good idea. But but the point is, to be included as a member of a guidance committee, it means that all of your peers think that you know more about this than the vast majority of people, and therefore you should be contributing to the guidelines. So are these people involved with expert guidelines? And there's a whole variety of different professional bodies that write guidelines for uveal melanoma, and NICE as well in the UK. And then the second thing is, has anybody written anything about uveal melanoma? And not just written something, but written it in a peer-reviewed way. Because the way scientific standards are kept is that you can't just publish what you think is a brilliant idea in a high-ranking journal if none of your peers think that it's a brilliant idea and think it's nonsense. That's the whole point. That's how peer review works, and it means that there's a selection process to get into the journal. So it's really easy for you to find that out. You can just put in that link. It takes you to a medical search engine, and you just put in the author's name, and you can put in an author's name plus uveal melanoma, and you'll see whether they've written anything. So peer-reviewed publications are far more meaningful than abstracts. And then the third important indicator of quality is whether this person has been invited to talk at any professional meetings, either to present their own data or to give an invited talk on something or other to do with eye melanoma. And you can see that in a Google search. I mean, all of these things you can see in a Google search. But of course, it needs to be on the relevant subjects, because most oncologists won't only treat eye melanoma, they'll treat a whole variety of other things. And what you need to know is whether or not they've got specific interest in eye melanoma. Okay. So my colleague Heather Shaw has just walked in, and she'll give the talk after me. And we are very directive about who we would suggest to our patients they go to for a second opinion. I'm not saying that we know everything there is to know about eye melanoma, and even if we did, for patients who are in difficult situations, it can be really helpful to know that all bases have been covered, you've had another look at the data, and you've got confidence in the decision making. So it's an entirely reasonable thing to think about getting a second opinion. But we will not be shy about telling our patients who we think they should go to for their second opinion. Because there are some people out there that I would just never ask time of day of, let alone a second opinion about uveal melanoma. And it's really difficult for you to know who they are. And it's difficult for you to, if you go to your GP or a relative or a friend, you still don't know. So we always offer to facilitate that second opinion. And then we've got some confidence that the patients that we care about very much are going to somebody who's going to give them some sensible advice. And so it's entirely reasonable Number one, for you to talk with your doctor and say, can I just speak to somebody else about it? And we're all really used for that. It's not a negative thing to them. You're not being critical of them. You're just wanting a second opinion. And then the second question is, who would you recommend that I go to? Next slide. Now, so what can you get? Well, you can get a set of eyes on the case. You can get an opinion, possibly from someone with additional experience. I think the main thing is usually the standard of care in the UK with melanoma doctors is excellent. And maybe I should have said that at the beginning. The quality of the UK melanoma community is really excellent. But you can have reassurance that the correct issues have been discussed and the correct decisions have been made. And you may get identification of different research options. We try to communicate between us what studies are available. We've got a melanoma focus meeting coming up next Friday, and all of the trials will be discussed there, so the community does know about it, but sometimes one doctor will know about something coming that another one doesn't, so you may get a feel for that. Next slide. It's not always straightforward, though, because some centres are refusing to receive out-of-area referrals for second opinions because of the workload. And that's entirely understandable. It is at odds with the NHS patient choice agenda. A while ago, there was a guarantee that you could have patient choice about where you go to, but the reality is that the commissioning pathways mean that you can't. Okay. You can ask for it, but you might not get it. Sometimes it means that patients go to the private sector for a second opinion, but I mentioned all of the quality indicators that I mentioned before apply equally in the private sector. So you've just got to be a bit wary about that. So I'm going to actually use, and I've not done this before, is to name a colleague, but everything I'm going to show you is in the public domain. And the reason I'm doing this is just to illustrate a point to you. And what I hope to do is illustrate the fact to you that this can be really difficult and subjective, because I'll have a view on this and other people will have an entirely contrary view. But I just thought I'd illustrate to you how difficult this could be. So Justin Stebbing, I trained with him. He's a high-profile oncologist. He's got not just many publications, he's got over 650 publications. It's extraordinary output. He's very, very bright. He had a chair at Imperial, so it's a high-quality institution. Remember I was talking about where to go to? It's a high-quality institution. And an extremely large practice in Harley Street and a very high profile and many celebrity patients. So Justin just avoided getting struck off, although he was suspended by the GMC for 9 months. And the reason that he was suspended for the 9 months is that a sample of his patients, when analysed, it turned out that 11 out of 12 of them died within 6 weeks of them receiving treatment. And the implication is that he was giving treatment that was inappropriate to patients at end of life. And the second implication from that is that he hadn't been honest with the patient about the potential benefits of treatment and the potential risks of treatment. Now, so he was found culpable of that and was suspended. Next slide. Yeah, so maybe just come back. So you can see the headline. So he was struck off. He avoided being struck off, I should say, after patients rallied in support. So I'm saying it's very difficult to, this is entirely subjective. So there's an awful lot of patients and a lot of celebrity patients who had very positive experiences with him and came to his aid when he was about to be struck off. So it's very subjective, and I think it's very difficult. The reason I'm showing you this is because I think it's just to illustrate the difficulties as a patient and relative trying to find somebody who you have confidence in to go to. So, and actually, there are kind of two camps of doctors. If you asked me who to refer you to for a second opinion, I would have never in a million years referred you to Justin. But I know colleagues who I have respect for who would have done. Okay, so it's subjective, it's really difficult. So what I'm illustrating is that even with all those quality indicators, well qualified, lots of publications, lots of trials, being at a good university, not only working in the private sector, it can still be really difficult. Right? So I wish it was more straightforward, but I do think that asking your oncologist for an honest answer about who would be good for a second opinion, for instance, is worthwhile. And generally, and perhaps this is an exception, generally, the quality indicators that I mentioned do apply. Okay, because this is very rare. So, as I say, it's usually fairly straightforward. You need to do a Google and PubMed search, make sure they've got a track record in the disease, ask your clinician for advice. They'll only want to help. I'm sure all of you, the vast majority of you will have very positive experiences in the clinical relationships that you've got. But I'm always a bit wary about patient testimony because it doesn't necessarily give insight into the quality of the decision making. It gives an insight into the quality, whether it felt okay or whether you're hearing something that you want to hear. But just because you want to hear something doesn't mean it's the right thing. And it comes into that. In fact, it comes into the next bit of my talk, which is just because you can do something, it doesn't mean that you should do something. And sometimes as an oncologist, some of the most difficult advice we give is about not doing something. It's quite easy to tell somebody to have this treatment or that treatment, but there are situations where you've got to be honest to say, maybe there isn't something more or whatever, or you put it in perspective. And that's as much a quality thing as getting the right choice for what to give to somebody. And that was something that Justin Stebbing wasn't doing. He wasn't making the decision about when not to treat somebody. So, okay. So I'm just going to move on to the next bit, which is the role of next generation sequencing. So the talk you just heard, my colleague from Liverpool talking about conjunctival melanoma, talked about the potential for personalised medicine. In other words, identifying what treatment would work for that particular patient's disease. And you heard me say at the outset, for the vast majority of times, despite what you've heard, for the vast majority of times, for uveal melanoma, currently there's no routine place for next generation sequencing. You are not missing out on anything and it would not make a difference. And I'll explain to you why. Okay. So Joe just said I should say what it means. So it means, next slide. This is what it means. So cancer is a genetic disease. It doesn't mean that you've inherited it, but cancer happens when you have genetic damage to genes that are involved in the control of a normal cell behavior. And if the wrong genes get damaged over time, they don't work properly, and it means that the control of a normal cell is lost and it turns into a cancer cell. And the two marks of a cancer is something that grows and spreads. If it just grows, it's a benign growth. If it grows and spreads, it's a cancer. And for it to do that, it means it's got to behave in an unregulated way. And if genes are working well, normally, there's regulation to stop that happening. But if your genes are damaged, and the wrong genes are damaged, the cancer happens. So the inherited genetic damage resulting in uveal melanoma is very rare. So there are families where there's a damaged gene that's passed down through generations, and you see an increased risk of uveal melanoma and other related cancers caused by the same genetic damage throughout multiple generations. It's very, very rare, but they're there. But the vast majority of mutations are acquired. And those are mutations that are only relevant in the cancer cell. So you haven't passed them on to your kids, you haven't inherited them. But there's modern technology that allows you to sequence, well, in fact, to sequence the whole genome, but in what we're usually talking about with next-generation sequencing is sequencing panels of genes that we know are important in biology of cancer and assessing what genes are damaged in the cancer cell and whether that allows you to do something useful to treat that cancer. Okay, next slide. So I'm going to use a few cliches that some of you might have heard before. These gene mutations can either be really important in making the cancer happen, so we call those driver mutations. You imagine your train, they're at the front, they're making the thing go. Or they could be passenger mutations, because when you look at the genome, the genes in cancer cells, there's lots and lots of damage in a whole variety of different ways. It's not just one or two switches that have been damaged. There's lots and lots of damage as well. It's quite difficult. And the vast majority of those mutations are passenger mutations. So the genes are damaged, but they're not the genes that are important in making the cancer happen. It's only fewer genes are the driver ones. So most genetic damage results in passenger mutations. It's a bit more complicated as well, because a driver in one type of cancer, a driver mutation in one type of cancer, could be a passenger mutation in another. In other words, the environment within the cancer cell, the type of cancer it is, affects the influence of the driver genes. And the reason that's important is if you pay £3,000 for your next generation sequencing report, you'll see a load of mutations, and then the report will say X, Y, Z mutations are known to be potential drivers, but they are not necessarily potential drivers in eye melanoma. Okay. Next slide. Then there's another level of complexity, which is what you can do about the information. So even when an appropriate mutation, well, a mutation is found in an appropriate driver gene, it may not be actionable. So actionable means that you may not be able to do anything about it. So no drug may exist. There's lots of genetic mutations that result in changes, and there's no drug yet that will affect them. Or a drug may exist, but it's not commercially available. Or there may not be any clinical trial data. Next slide. So clinical trials are still essential, and the reason they're essential is that partly because what I said before, that a driver gene in one cancer may be important, but the same mutation in another cancer may be unimportant. So unless you do a clinical trial in the relevant cancer, you're not going to know whether or not that mutation is important. And secondly, despite all of the computer modeling and animal experimentation you can do, the ability to predict benefit and toxicity is still really limited. Now, interestingly, for eye melanoma, even though, as you all know, it's a disease that we have inadequate treatments for, interestingly, the genetic mutations that drive it are really well understood for uveal melanoma. Next slide. So you may not be able to see this, and apologies for that, but eye melanoma, as you know, is entirely distinct from skin melanoma. And there are just a handful of mutations that are drivers, that are what we call foundation mutations, important at the beginning of the cancer generation process. 90% of eye melanoma, of uveal melanoma cancers have mutations in a couple of genes. One's called GNAQ, one's called GNA11. So 90% of those. And then there are a couple of other drivers that are much lower frequency. And then with cancers, you get additional things, additional damage happening that makes the cancer cell behave in certain ways. And we know that you would have heard of a gene called BAP1 that can affect the ability of cancers if it's not working properly. And you can then kind of categorize eye melanoma into different groups depending on what mutations happen. But actually, the mutational landscape in uveal melanoma is really quite bland compared to many other cancers. So we know not a lot about this. Next slide. So I mentioned eye melanoma. 90% of patients have this GNAQ and GNA11 mutations. So what they do is they turn on some pathways in the cancer cell, and along those pathways, there are some targets that have been really useful in some other cancers. Okay, so the logic is, well, if you've got those pathways turned on in eye melanomas, why not use those same things that have been useful in other cancers in eye melanoma? So if you do a next generation sequencing on almost anybody's uveal melanoma, you'll see a report that says it's got an activating mutation in GNAQ or in GNA11. That predicts for this pathway activation. The pathway is called MAP kinase. And that predicts for something called a MEK inhibitor. It's part of that pathway. It predicts for MEK inhibitors to be helpful. And we use MEK inhibitors for skin melanoma and for some other things. But, next slide, we've done the clinical trials. And the clinical trials with MEK inhibitors for uveal melanoma are pretty much negative, certainly not positive enough to make any difference. And that's why none of you are being treated with MEK inhibitors, because we've done the clinical trials. But it doesn't stop the next generation sequencing report coming out saying this patient may benefit from a MEK inhibitor. And unfortunately, going back to the first part of the talk, it doesn't stop somebody who doesn't know enough about the disease recommending a MEK inhibitor on the basis of a next generation sequencing report, because that's what the report says. But we've done the clinical trials that show MEK inhibitors don't work. Okay, so you've got to interpret the data in the right way. Next slide. Now, actually, there are other targets on those activated pathways that there are some drugs in development for that are looking interesting. And I've just put up, some of you all know that there are some studies with a couple of new drugs, darovasertib and crizotinib, that block the pathway that I just mentioned. And those, we call those waterfall charts, waterfall plots. And each bar is the tumour burden in an individual patient. So each bar is a patient. The x-axis is the size of the tumour before treatment. And if the tumour shrinks, the bar goes below the x-axis. If the tumour grows, it goes above the x-axis. So you can see the vast majority of these patients, each bar is an individual patient, their cancer shrank. Okay? So we're obviously, some trials that Heather mentioned, looking at that. So the reason I put that on is that we do need to know what these genetic drivers are. We do need to know what pathways are activated. And we do need to do the clinical trials to test whether or not those pathways, blocking those pathways, result in benefit. But just knowing the pathway doesn't allow you to predict that your drug's going to be helpful, which is why next generation sequencing alone, in the absence of clinical data, is not helpful. So in summary, the promise of an effective personalized medicine for advanced melanoma is not in most cases delivered by next generation sequencing. I think it risks promising the undeliverable. So if you go and see somebody and they say, well, we're going to find out all the details of your cancer and specifically find the right drug for your cancer, that's not going to happen. So it risks promising the undeliverable, it risks raising inappropriate expectation and hope. And actually the consent process for next generation sequencing should be explicit about that. So the mechanisms of resistance in uveal melanoma are not driven by the acquisition of new single targetable mutations. Okay, so that's why it's not helpful. But rarely there are some specific situations where it might be helpful. So like everything, you've got to be kind of careful about it. So for example, in pediatric uveal melanoma, which fortunately is ultra rare, there is a genetic mutation that potentially, if it's present, means that that cancer is more visible to the immune system than the majority of uveal melanomas, and we would want to know about that because we would use a different strategy for those patients. So it can be useful, but you've got to be wise about it. And I think that's everything that I was going to say. Thank you.